Doran Mix, and I just completed my year-out fellowship as a CTSI medical student fellow, specifically working on my project looking at how to improve the patency of AV fistulas used for hemodialysis, and as well as other work involved in looking at strain and stress analysis of abdominal aortic aneurysms and fragility of echo contrast. Before we had the concept of stressing abdominal aortic aneurysms, we needed the ability to stress abdominal aortic aneurysms with a simulated heart. And traditionally in the past, animal models have been used to do these experiments, but unfortunately animal models are very expensive and non-reproducible. So what we invented was an artificial heart. We used a 3D printer to print this ventricular chamber, and it's the same size as an adult male heart. And then we used a computer controller to use a piston to squeeze this heart in the exact same manner that a real human heart would be squeezed. And you can see on the monitor here, we can then create realistic pulsation. This monitor is a real monitor that would be used in the ICU. And you can see that we have a realistic hypertensive male with a high systolic blood pressure and a relatively low diastolic pressure relative to the pressure, and that we're flowing 3.2 liters per minute, which would be the similar output of a person with a pretty poor heart function. But this allows us to create realistic pulsations into a system where we can very easily control the system. And the real question that we're trying to answer is, instead of using traditional models where we just use the size of the aneurysm, so how big is this bulge, we want to know actually when the tissue is going to fail. And so this model that we have here is from a real patient, but we've modeled both, as you can see, the radius all the way down, as well as the thickness of the wall of the artery, and both of those can cause failure. And ultimately in this experiment, we're going to use the heart pump and pump real pulsations from a simulated heart into this aorta, and then slowly step up the pressure until the point that we see a rupture. And by studying that very specifically under ultrasound, we can start seeing where the wall is starting to fail, and ultimately that will give us a way to go back to patients and say, okay, I'm seeing these same conditions just before failure in your aneurysm as I saw on the model on the simulator. We're pulsating the aorta just as it would inside the patient, and then we're actually looking at the aorta under ultrasound. We can see thrombus in the wall of the aorta, and we can actually see how the aorta is stretching. And where the failure location is going to occur is where the points on the wall are moving most dislike each other. So you can imagine in a rubber band, if you stretch a rubber band, where the rubber band breaks is the point at which the forces are maximally in opposite directions. So the same in the case for this aorta, we're looking for the point, just like on the rubber band, where the two pieces are moving most dissimilarly. And we can study that using ultrasound strain analysis to determine where that failure is going to occur. You see the hole? We would have been able to tell under ultrasound where that hole was going to happen before it did. I remember Dr. Pearson once saying that the more collaboration we have, the better things and the more quickly we'll get things done. Mallory Wingate is specifically responsible for the abdominal aortic aneurysm project that you saw. So we kind of conceptualized the idea and had some ideas of how to make these patient-specific aneurysms, and then Mallory, in true engineering style, made it happen. So basically taking the patient CAT scans, rendering three-dimensional images, and then taking those three-dimensional images, using a 3D printer at RIT to actually mold what the aneurysm looked like, and then making the molds and actually casting the molds, and using this material called hydrogel to model the mechanical properties of vessels. Jeannie Giannotti specifically is working with Carl Schwartz, Dr. Carl Schwartz, looking to study the effects of echo contrast and specifically how echo contrast decays under certain hemodynamic or pressure conditions, as well as how ultrasound contrast decays because of ultrasonic energy. So ultrasound produces energy and can cause cavitation of bubbles, and we're specifically looking at how specific settings within the ultrasound machine cause certain decay rates of bubbles. The reason these bubbles are important is they're used all the time in clinical medicine to look at ventricular volumes, as well as to look at perfusion of tissue and things like that. If we understood how ultrasonic energy destroyed those bubbles, we could start developing therapeutic modalities such as delivering drugs through the bubbles themselves to specific targeted regions where we focus the ultrasound, as well as being able to do things like cardiac output measurements more effectively. It's every engineer's dream to have kind of a carte blanche opportunity to apply their ideas. I think it's an amazing opportunity. I think there's some hesitations when you're going through the rigors of medical school to just kind of continue on the path, and there's kind of this preconceived notion that if you just don't do things in the systematic steps that you're supposed to do them, that you're not going to have the end result you want. And I can assure you that's just not true, and the opportunities that a year out gives you are absolutely endless. And it's really exciting to be able to apply your own ideas and try out what it would be like to be a scientist for a year. And it definitely has empowered me to want to continue research for the remainder of my career.